Hello, welcome to the Neuroblastoma Parent Global Symposium 2021. My name is Callie Calverts. I'm a neuroblastoma survivor, and I will be moderating the first part of this session entitled Survivorship, which is delivered by Dr. Lisa Diller, who's the Vice Chair of Department of Pediatric Oncology at Dana-Farber Cancer Institute. But before I hand it over to Dr. Diller, I'd like to draw your attention to the panel on the right side of your screen where you can submit your questions. There's the option to do so anonymously if you choose. Questions will be addressed after the presentation has concluded. So over to you, Dr. Diller.
Thank you so much for having me. Can you hear me okay?
Yes, we can hear you great.
Great. I'm going to take a few minutes and talk a little bit about neuroblastoma survivorship. I can't see the questions as they come in. I can only see my own slides. So if there's a problem or anything, somebody shout out and I'll go from here. I thought I'd introduce myself a little bit. When I was in training as a pediatric oncologist in the late 80s and early 90s, high-risk neuroblastoma was one of the most dreaded diagnoses that we dealt with as trainees because very, very, very few children were cured. We saw very few survivors. I was interested in childhood cancer survivorship, and I started the survivorship clinic at the Dana-Farber, and we saw very, very few neuroblastoma patients, high-risk neuroblastoma patients. And we saw a lot of leukemia patients who had really terrible side effects from the radiation that they got, from the chemotherapy that they got. And the 20 or so years that followed that in leukemia were devoted to reducing the late toxicity associated with leukemia, which in the 70s was an incurable disease. So now that we have curative therapies for many patients with neuroblastoma, I feel like we've sort of gone around again, and we are thinking about all the survivors of high-risk neuroblastoma that we take care of, and how, although those patients survive, many of them have a high burden of toxicity from the therapy. And it's our job as oncologists to do what we did in leukemia and figure out better ways to treat patients so that they have fewer toxicities. So with that introduction about myself and how my career has sort of come around as a neuroblastoma doctor and a survivorship doctor, I'd like to tell you a little bit about neuroblastoma survivorship, focusing mostly on high-risk patients. So what are the major questions in neuroblastoma survivorship from the point of view of an oncologist? One is, what are the issues of care of survivors of low and intermediate risk patients? Because it's not without toxicity to survive those diseases. And as more and more high-risk patients survive, what's the outcome for them? What's the risk of late recurrence and the risk of late mortality or morbidity, illness? And can we identify intervention strategies to reduce long-term morbidity? And how can we best take care of our survivors? Let's take a minute and talk about low and intermediate risk therapy. Historically, good disease control outcomes came with chemotherapy, surgery, and radiation, but more recently, clinical trials worldwide support the success of reduction of therapy trials. We've been able to identify those patients with clinical or biologic factors in their tumors that are likely to be cured with much less aggressive therapy, including observation only, no chemotherapy, no radiation. In general, we try to minimize the use of radiation and surgery if possible, and reduce chemotherapy when needed to reduce the total dose of exposure. But even when children get only surgery, there are problems that we need to follow them for. Here's an example from a group I work with in the United States, the Childhood Cancer Survivor Study, just showing the incidence over years, over 30 years, of children who've had abdominal surgery in developing small bowel obstructions, often needing hospitalization or surgery. So even having big surgeries have late toxicities. On the left is an X-ray showing dilated bowel loops, and on the right is a cumulative incidence, meaning how often we see patients who develop late intestinal obstruction. In the United States, we treated intermediate risk patients with a combination of chemotherapy and tried to avoid radiation, tried to avoid high doses of chemotherapy so that we would expect to avoid many of the late effects associated with those high doses. So even though we give drugs that are associated with infertility or cardiac disease or hearing loss or renal disease, the total doses of therapy that we give for intermediate risk therapy for intermediate risk patients is expected to not result in any of those outcomes. And the outcomes have been excellent in terms of overall survival and event-free survival, or the chances of relapse are very, very, very low. But even with that therapy, a small number of patients, so 3 out of about 300, developed leukemia from the chemotherapy itself. And, for those 3 patients, this is a life-threatening situation. And so the question remains, can we get rid of those drugs that are associated with secondary leukemias? So the next steps in low and intermediate risk therapy, which I'm sure you've talked about over the past 2 days, include expanding who doesn't need surgery at all, who can get fewer cycles of chemotherapy, how can we use less aggressive surgery, and how can we improve care for conditions that are associated with late toxicity, like patients who have symptomatic but low risk neuroblastoma, who might have like a Horner syndrome or some other toxicity of their therapy, opsoclonus myoclonus, a neurologic condition, but associated with a good chance of being cured of your neuroblastoma, but often with late toxicity. Let's turn to high-risk neuroblastoma. I'm sure that over the past 2 days, you've talked about many of the different ways worldwide that doctors are figuring out how to effectively treat high-risk neuroblastoma. This is a slide that kind of just shows the percentage of patients within a number of studies kids who've gotten all different kinds of therapies from around the world, and the likelihood that a child in that particular study would have a side effect of one of these areas of toxicity, so cardiac toxicity or pulmonary or kidney or growth, etc. So it gives you a sense that, one, we don't have really reliable estimates of who from what therapy, who gets what toxicity, and 2, that no matter where you've been treated from around the world, there is a high risk of toxicity. So we decided to, and there's so much we don't know because of some of the newer therapies that haven't really been reported, like I-131-MIBG and isotretinoin, which is also known as cisretinoic acid, immunotherapy, ALK inhibitors. We don't really know the late effects of any of those. One of the questions that has been raised is, what's the risk of late relapse? Once you start taking care of survivors, you often are asked the question by parents and by patients, what's the chance that my neuroblastoma will come back? And then if it comes back, what's the cure rate for that? What are the late effects of the newer agents, as I mentioned? What late effects can we avoid by changing therapy now? What clinical trials should we be doing by changing the therapy that we offer? And how can we better take care of survivors so that they don't develop late toxicity? And finally, what are the genetic components that explain why some people get late effects and others don't? This is a slide that we prepared, or a study that we prepared, finding about 500 patients in the children's oncology group who did fine, never had a relapse at 5 years from diagnosis of high-risk neuroblastoma. And we looked at what's the likelihood that they will develop a relapse if they've made it 5 years. And this was the study that we did a few years ago to look at that question. And what you can see here is that almost 90% of patients 6 years after that 5-year time point, or 11 years later, are surviving without a relapse. That's pretty good. It's not good enough, but it's pretty good. And we're happy to hear that late relapse is not a common problem in high-risk neuroblastoma. So my colleagues and I decided that we would do a study to really hone in on what the late effects of high-risk neuroblastoma are. We call it the LEARN study, and we've just completed enrollment in that study. The study was designed to understand the prevalence, or how common the late effects are, what the risk factors are, including treatment-related risk factors, demographic-related risk factors. Do some kids have a higher risk because of age, race, ethnicity? the impact of treatments and toxicities on quality of life, and to collect biologic specimens to understand the genetics of some of these late effects. We enrolled patients from all over the children's oncology group, and we made sure to enroll patients who were diagnosed after the year 2000 so that we didn't get too many patients who had historic therapies that we're no longer using. And they had to be at least 5 years from diagnosis. And patients submitted audiograms, echocardiograms, bone age, a dental study, pulmonary function studies, and laboratory evaluations, as well as a physical exam, an assessment of their medical conditions, their medications, whether or not they developed a second cancer, their fracture history, and their pubertal and reproductive history. We just finished enrolling all our patients. This gives you an idea of who these kids are. So they're about 10 years from diagnosis, and the range is from childhood through early adulthood. They were treated, as you might expect, on children's oncology group protocol, so a little different than the European trials, but with a variety of therapies. One thing that I think is very interesting is that most of them got radiotherapy, about half of them got immunotherapy, almost all of them got Accutane or cisretinoic acid, they almost all had transplants, and they had a lot of MIBG scans, and we'll be looking at the toxicity of MIBG scans as well. Here's the first blush look at the data where we find the reported toxicities. So a large percentage of patients have hearing loss. That's pretty significant hearing loss. You're only included in that number of almost 70% if you required hearing aids. A smaller percentage had cardiac or pulmonary toxicity. A bunch have endocrine conditions, and a small number have developed another cancer. I'm going to take a minute to look at this slide because growth impairment is something that we're really kind of worried about. If you look at the red curves, that's the distribution, that's called a normal distribution that you would expect in a population. So 50% of people should be sort of right at the median or so of having, of their height. So it's the distribution of height. And you can see that in the neuroblastoma survivors, the distribution of height is shifted way downwards. So this is concerning. Short stature is something that we're observing. We don't really know why that is. We don't know what's causing that. We're also really interested in quality of life. The patients filled out, or their parents filled out, a number of forms that help us and the psychologists that we are collaborating with to look at some of the behavioral, social, and neurocognitive outcomes. You can see here that a majority of kids, 61%, participated in a special education program. A big percentage had special services for hearing impaired individuals, and a smaller percentage needed to repeat a grade. So our study plans, we've actually just completed enrollment. We're doing data cleaning and assessment of missing data. We're integrating our data with the COG so that we can really know how selective this population is. And then we'll be doing, as I mentioned earlier, those risk factor analyses. So in conclusion, and before I take your questions, high-risk neuroblastoma survivors face a range of health challenges. We see a very high risk of ototoxicity or hearing loss in COG patients and significant growth impairment, even though we're no longer using total body radiation, which is what we thought was causing growth impairment before this study. We have hopes for international collaboration so we can really understand the differences in toxicity between the way we treat patients in North America and how patients are treated in Europe and other places. And we're really wanting to know if we can design studies that make these late effects less common or less severe. I want to thank my colleagues in the LEARN study, the members of the neuroblastoma and the survivorship research community who have contributed to this, to the parents and patients, and to you for inviting me to talk today. Thanks very much.
Thank you, Dr. Diller, for your very interesting presentation. So we've got our first question for you, Dr. Diller. The first question asks, they're interested in your thoughts on the overall survival for relapsed neuroblastoma these days. Many doctors still quote that less than 10% have a 5-year survival.
I don't know the answer to that. It's very, very hard to know because most of the data that are available have rather short-term survival data. So certainly it's more than 10% at 2 years or at 3 years, but 5 years is very hard to estimate.
Okay. Our second question, did you find a gap or a dip in service provision regarding long-term follow-up, i.e. when transitioning to adult care?
That's a really great question. This is a problem overall in pediatric cancer survivorship research and pediatric cancer survivorship care. Different countries and communities have dealt with this different ways. I can tell you about our experience. As children age and become young adults, we find that the children who have diseases that internists or adult doctors have less familiarity need to stay in pediatric care longer. The idea being that if you had Hodgkin's disease or lymphoma or leukemia when you're a teenager and you transition to adult oncology care, the doctors who take care of you on the adult side are often very familiar with those diseases. Neuroblastoma, on the other hand, is an extremely rare disease. The therapy has changed over time. There are not a lot of survivors yet in the community for people to be aware of how to care for them. And so we tend to keep our high-risk neuroblastoma survivors under the pediatric care with adult consultation rather than releasing them to adult care. I don't know the answer for every healthcare system. This is a very difficult question. One thing I do recommend is that every patient who's a survivor of high-risk neuroblastoma have something called a treatment summary that summarizes what treatment they received. And often a treatment summary will give information about the toxicities that need to be monitored, for which a patient needs to be monitored, whether they need echocardiograms or hearing studies, what their risks are, so that the less informed physician who's taking care of the patient is more aware. For example, showing up to an emergency room with a small bowel obstruction, it's good to know what I taught you today, that if you had abdominal surgery for neuroblastoma as a child, you have a 10% risk of developing, or 5 to 10% risk of developing a small bowel obstruction sometime in the next 30 years. It's kind of hard for a doctor in an emergency room to know that fact when neuroblastoma is so rare.
All right, thank you. And question 3, has the LEARN study been developed in partnership with young people who survived this disease? Are the things which are most important to them included? That seems most important.
That's a great question. We actually included parents. We did not have teenage or young adult advisors in the LEARN study. We are preparing what we're calling Learn 2. So our next study, our goals there are to follow these patients or re-enroll these patients as they go through that transition through, the median age right now is 12. So as they go through that sort of adolescence, young adulthood, to figure out ways that they can sort of contribute and independently care for themselves. We're hoping to use kind of more modern techniques of contacting patients like social media, et cetera, and keeping in touch with them because we think that that's the way of the future. So I take that advice to heart. That's a great suggestion.
All right, our next question says, thank you for looking at this. And what are the common neurocognitive and endocrine effects that you observe?
Endocrine, the biggest one is growth. I'd say that was the most common. We have patients who have thyroid failure, meaning they need to have thyroid hormone replacement as part of their treatment. That can be as part of their chronic treatment. That could be because of a therapy that affected their thyroid. It also could be because of incomplete blockage of the thyroid when an MIBG scan is delivered. That MIBG can be toxic to the thyroid, or from MIBG therapy itself. The other endocrine problems that we've seen include problems with type 2 diabetes, which we think might be due to the radiation to the pancreas. That is something that we will be looking at, if whether or not that's more common because of pancreatic radiation. The endocrine system includes the system that makes your ovaries change to go through puberty or ovarian function, as well as the production of testosterone. Most boys go through puberty without exogenous testosterone, meaning having to take testosterone, but often girls need to take estrogen in order to go through puberty after neuroblastoma therapy. That's a side effect from a class of drugs called alkylating agents like busulfan, cyclophosphamide, ifosfamide, and other drugs, thiotepa, other drugs that you might have heard of that are given for high-risk neuroblastoma.
Very good. Very good. Question five. Would you neuroblastoma example?
Could you repeat that? You're breaking up a little bit for me.
I'm not sure what's going on. Would you recommend the neuropsychological exam for the kiddos that are NED or post-treatment? Our child is a 3-year survivor, and in the past year, it seems like she is having challenges with focus, patience in school, and sometimes eye twitching more than usual. I only found out about this type of testing through speaking with our other survivor families. Just wondering your thoughts.
I think I think it's a great idea. I think that having gone through the kind of therapy that she must have gone through, there might be neuropsychological components of that. Obviously, we've just lived through a pandemic and there's a lot of stress on children in general. So I don't want to discount the possibility that this could have happened anyway in terms of difficulty with focus, etc. But I think neuropsych testing is a really good idea. Also, children who've had hearing loss can have neuropsychological testing can help them as well, because that hearing loss can impact upon their learning ability.
Okay. Very good. Number six. Dr. Diller, for the kids that have already received these toxic treatments, is there an early intervention we can do as parents to prevent some of these side effects? It seems to us that there are no protocols for monitoring. We as parents have to educate our own doctors by reading. There are no guidelines.
So I would suggest there's a number of ways to address that as a parent who's advocating for your child. One is that there's a set of guidelines that are a little difficult to read, but given that you're at this meeting, I bet you can do it. They're called the Survivorship Guidelines, and they're at the Children's Oncology Group website. I think it's survivorshipguidelines.org. I'm pretty sure that's the website. You can go there and then go treatment by treatment that your child received, so that you can know what the toxicities are, the concerns or the risks that doctors have, and what the recommended testing is. For example, some patients who've had high-risk neuroblastoma or intermediate-risk neuroblastoma have received a drug called doxorubicin, or adriamycin is another name for it. There are specific recommendations based upon the total dose that the child received in terms of monitoring by echocardiograms for heart disease associated with that agent. So those are spelled out drug by drug and treatment by treatment in that document. It's a big PDF document that you can search by treatment. Another way to approach this is to identify a survivorship program near your hometown or your community. In the United States, most big pediatric oncology centers have them, and in England as well. In England, I believe they are stratified a little bit so that only certain patients go to specialists in follow-up versus are cared for by their GP, but I believe high-risk neuroblastoma is a criteria for being followed, and someone can correct me if I'm wrong, for being followed in the national health system by a specialist. And then, yes, of course, there are things, most of what we do, unfortunately, right now is observation, early detection of late toxicities, and changing the care of a patient based upon what we detect. What I'd really like to see is more prevention, so that during or after therapy, we can give other therapies or modulate the therapy so that patients who are at risk avoid developing those toxicities.
Very good. All right, our next question, is there active international collaboration to identify best practice related to long-term care?
Yes, there is. There are international harmonization guidelines similar to the ones I mentioned from the Children's Oncology Group that are published. I don't know if they've put together any parent-friendly or patient-friendly materials, but we can find out for you. We are working as an international community to identify the best practices for all childhood cancer survivors, mainly based upon exposure. If you got X drug at Y dose, what kind of follow-up should you get?
All right. Next question, what are some characteristics of patients with late relapse?
Yeah, it's a really great question. I don't know what the risk factors are for late relapse. I don't know that there's been a good study depending upon what you define as a late relapse. There have been some rare patients who've relapsed 10 years after, more than 10 years after their treatment was completed, or 5 years after their treatment is completed. And I would guess that if we could look really closely at that, older age at diagnosis might be associated with a late relapse risk. But to be honest with you, I don't know that we've looked at that very carefully.
Okay. Our next question, are you seeing long-term psychological problems in kids? My son seems to have PTSD and developed OCD tendencies, although we are still in treatment.
I would say that I've seen a remarkable amount of resilience in high-risk neuroblastoma patients. I've been incredibly impressed at their adjustment despite what they've been through. Obviously, as I said earlier, going through neuroblastoma therapy especially high-risk therapy, is very traumatic. And a psychologist helping a patient through that, it would be a very important thing. It's also been a really rough couple of years in general. So again, the burden of psychologic illness in children in general, regardless of, without regard to neuroblastoma or other cancer, is enormous. Our emergency rooms here and throughout the world, I think, are full of children who are suffering at this time presumably because of some of the stresses that they've been dealing with in the pandemic conditions.
Okay, what is known about the phenomena of chemo brain or brain fog post-chemotherapy treatment? How is it identified? What role does the education sector have in supporting children who experience this? And how can parents and healthcare professionals best advocate for the support of their child may need?
That's a great question. I think most of the brain fog or chemo brain data are accumulated in adult patients, adult cancer patients, and much less so in children. Most of the studies in children have focused more on learning and neurocognitive outcomes rather than what many adult survivors talk about in terms of the term chemo brain or brain fog. The risk factors for cognitive loss in after cancer therapy include cranial radiation. So if your child had neuroblastoma that involved sort of any area above the neck, there might be some effect of that on learning. The other drugs that have been associated with kind of that chemo brain are generally not given to children with neuroblastoma. And then, as I mentioned, there's a great deal of concern about hearing loss and its impact on cognitive function. The other issue that I think is important is neuroblastoma therapy can be quite long. High-risk neuroblastoma therapy is approaching a 2-year package at this point. So children will be impacted by loss of contact, of social contacts, missing school or other environment that they might have been in normally, interaction with siblings, etc., that might affect their cognitive development.
So on the topic of hearing loss, would you anticipate noticing a change soon after tandem Bumel or cycle thiotepa plus rapid Kojek? Sorry for mispronouncing those. We hear so much about hearing loss, and even though audiology tests are good, 1 year post-transplant, can it still deteriorate?
So, I do think the North American approach is associated with a much higher risk of hearing loss given the drugs that we use. So rapid Kojak and the therapies that are used for transplant in Europe are expected to be less associated with hearing loss than the ones we use in the United States. Usually, if there hasn't been hearing loss a year after therapy, there's usually not acquisition of hearing loss, but it's not 100%. And then also, if there's been radiation, that's a risk to the hearing apparatus. So anywhere kind of where the hearing, the cochlea, and the other hearing apparatus sit, that can be a risk factor for deterioration. Kids who sit in transplant rooms can sometimes be in a room that has a loud fan that's going, and they're there for a month or two, and that can cause hearing deterioration, as well as some of the other drugs we give, like antibiotics or diuretics. So it's not a free ride, even if you don't get the really toxic stuff that we give in the United States for hearing.
Okay. Dr. Diller, do you think that the numerous anesthetics that neuroblastoma kids tend to have contributes to their difficulties concerning in school due to neurotoxicity?
That's a really great question. The data on frequent anesthesia and cognitive loss is confusing and difficult to interpret because obviously children who have frequent anesthesias have underlying medical issues that cause them to have frequent anesthesias. So it's very hard to know how to interpret that. One of the things I have noticed over my years in the field is that the anesthesias are much easier. The drugs that we have for anesthesia are much less the time under anesthesia is much less prolonged and the recovery is shorter. Unfortunately, years ago, we used to do a lot of the things we do now, like bone marrows with local anesthesia, and pain was an issue. And so when you ask people what they remembered about their cancer treatment, what they remembered was pain. And PTSD is very much associated with having had pain as a child. So you're sort of weighing that balance between using anesthesia with some worries about cognitive problems or toxicities of frequent anesthesias avoiding pain. And so safe, brief, rapid recovery anesthesia seems to me to be a better solution than avoiding anesthesia.
Sure. I think we've got time for about one more question. Is a treatment summary issued as standard, or is this something that parents and patients need to ask for?
Well, it should be standard. Parents and patients should always ask for it. Pediatric oncologists around the world know about this at this point. This has been around a long time. It is an undertaking when you see a 25-year-old who hasn't been seen in 10 years asking you for a treatment summary from something that happened when they were 2. It's an ask. It's something that a doctor or a nurse practitioner needs to do, digging out those old records and figuring out what to tell you about your prior therapy, but it is a standard and it's something that you can certainly ask for.
Very good. Okay, I think we'll squeeze in one more. Is there an ideal age that treatment should be started for growth problems?
Oh, that's a great question. Well, If you're referring to growth hormone, that has to start before there's fusion of the growth plate. Otherwise, it doesn't work. So yes, it needs to be started early, generally before puberty. This is a complicated question because generally neuroblastoma patients are not growth hormone deficient. So the role of growth hormone in promoting their growth is not entirely clear. Although the LEARN study will hopefully get at that better because we will have all that data. Some suggestion in other treatments for growth, however, can start very early. One of the things that we have noted is nutritional problems, that children are not growing because they're undernourished. They had 2 years of therapy. They were quite ill. They might have developed food aversion or had a G-tube. So start making sure that adequate nutrition as soon as possible, including during therapy, is applied, that patients are getting enough nutrition is really, really important because I do believe that that does impact upon growth impairment.
Very good. Well, that is all the time we have for questions. So thank you very much, Dr. Diller. And now I'm going to hand it over to Pat Telongin for the second part of the session.
Thank you, Callie. Appreciate it. And that was a great presentation, Dr. Diller. My name is Pat Telongin, and I'm from the Children's Neuroblastoma Cancer Foundation. Soon, I'm going to be joined by neuroblastoma survivors John and Julia. But first, we would like to have you watch the introductory videos of John and another neuroblastoma survivor, Jay, who could not be with us today, but we wanted him to share his story with you. So please watch the videos of John and Jay. Thank you.
Hello, everyone. My name is Jay Ferrick. I want to thank Pat for inviting me to speak again. This is my third time speaking at this conference, and also thank you to Pat and her team for putting on this amazing conference. I know my parents said that they would have loved for a resource like this when I was going through my treatment. I'm going to briefly give you my story and as quick as, not quick as possible, but a little shorter than years past. So bear with me. So also I'm currently in Northern California, in Petaluma, just north of San Francisco, and I'm 27 years old. So my story with neuroblastoma started in the year 2000 when I was in kindergarten. I started limping over my winter break. I got stung by a bee in the forehead, and my parents thought that maybe I also had stepped on a bee or got stung by a bee, and that's why I had started limping. So they asked my teacher to look after me at recess and in class and see if I was limping or if I was just trying to trick my parents and get myself to stay home from winter break longer. My teacher said, sure enough, I was limping. So I went and got checked out from a doctor. Doctor couldn't really find anything. They thought that maybe I had some hip dysplasia or a bone disease. So I went and got checked out for that. They didn't really find anything. 2 weeks after that, I started really having bad stomach pains. And the doctor felt around my stomach and he could feel a tumor. They did an ultrasound and discovered a tumor the size of a grapefruit, and it also was metastasizing. At this point, we found out that I had something called neuroblastoma, that we had no idea what that was, and cancer wasn't even one of the thoughts that we thought the limping could have spurred from. From then on, all my treatment was at UCSF Children's Hospital in San Francisco. My parents sat down with the doctors and mapped out a 14-month treatment plan, and that plan started with 5 to 6 rounds of chemo to reduce the tumor from the size of a grapefruit to a golf ball, so that they could have surgery on it and remove it. So back to chemo. My parents stayed in my room with me during this time, in the uncomfortable fold-up chair that's next to the bed. And we also stayed at the family house across the street. After my initial rounds of chemo, they shrank the tumor to the size of a golf ball, and then I had surgery, and they removed the remaining parts of the tumor. This was 6 months after my initial diagnosis. My tumor was on the right side above my adrenal gland. Now I currently have a scar that I call my shark bite that goes from my belly button all the way up to my armpit. When people see me with my shirt off, they ask what that scar's from. I tell them my shark bite, and they look at me like, really? And then I smile and can't hold it back and just let them know, no, actually I had a tummy tuck surgery. No, just kidding. No, I told them that I had cancer. So after the surgery to remove it was my stem cell transplant. I was in the same room for about 40 days. During that time, I didn't eat for 3 weeks of those 40 days, and I had a feeding tube down my nose. That was the only way they could get me to eat. And I was down to 35, 40 pounds for a 5-year-old, which was pretty slim. The only part I really remember about this was that I got chicken nuggets for my first meal in my room, and that's all I remember from my stem cell transplant. I didn't tolerate it very well. I had a super high dose of chemo preceding the transplant. But I do remember from the transplant that I got to exit through big double doors, and doctors and nurses lined up with toilet paper and made a finish line for me to break through. And I was done with my stem cell transplant and broke through the toilet paper. After the stem cell transplant was radiation. This is the easiest part of my treatment in regards to how my body handled it. They did an intraoperative radiation during the surgery that removed my tumor. The radiation went for a week, and actually it was only 3 days of that week. After the radiation, there were still some active cancer cells. So the next step was to take 13 retinoic acid, which is actually Accutane. My dad took Accutane in high school, he said. In comparison, he was 200 pounds taking 40 milligrams. I was 40 pounds taking 200 milligrams. The last part of my treatment was a phase 1 study. I was a part of the CH14.18 antibody therapy phase 1 study. In 2001, they did not know much about CH14.18, and the study on myself and some other neuroblastoma patients were to see how our bodies could tolerate it. At one point, I could not tolerate it, and they had to stop and cut the dosages in half. This was what my parents said was the hardest and scariest time for them, just because I was so drugged up, and it was really hard on my body, and they didn't really know what was going to happen next. But after the phase 1 study, my 14 months of chemo were up, and I was cancer-free. So I would return to UCSF from then on every 3 months for MIBG scans and CAT scans and blood draws and VMAs, and then 6 months out, and then I'd come back every 9 months, and then every year, and then every 2 years, and now I've been in remission for almost 21 years, or it's been 21 years actually. I think September was 21 years. I currently live a very healthy life. Most people were surprised when I tell them I had cancer. You wouldn't know from looking at me. Some of the side effects that I had are pretty minor. I'm pretty lucky, but I have super high arches in my feet. My fingers are kind of curved. They don't go like straight together, and that's from vincristine, one of the chemos. And then I also have poor circulation in my fingers and toes. It's also from vincristine. My fingers go white and pale and numb when it's like 50 degrees out, so not even that cold. I also have a really hard time gaining weight, and I think that might be due to part of my stomach was, I think, compromised during the surgery. I have one of my kidneys shriveled up and was damaged, and I also have that scar that kind of serves as a tummy tuck surgery. Psychologically and learning, I never really had any issues. Some things looking back, I really looked forward to going to the hospital actually when I was 5 or 6, because they treat you as a a king when you're the patient. They're even letting you play video games. You're getting to eat ice cream whenever you want. People are giving you gifts. So when you're that young, you really don't know what's going on. Another thing that was tough for me was I could not swallow pills. So because of that, I had to crush up the pills or pop the pills and put them in something. So I would put medicine inside of root beer, apple juice, mint chip ice cream, and something else, and grape juice, 4 things. So I don't like any of those still to this day because they remind me of the medicines I took. I still can't swallow a pill besides maybe ibuprofen. If it's any bigger than that, mentally I can't do it. So that was some of the challenges. That was my treatment. This I know was super quick. I'm gonna scroll through my notes and see if there's anything else I could speak about. I know that the nurses and doctors were, like I said, what really made this experience a positive as much as it can be, because the nurses were my best friends. When I was losing my hair, I actually was pulling the hair out, and my parents just let me cut it into a mohawk, and I dyed it green and blue, and all the nurses dyed their hair green and blue with me. Or not just green and blue, they did whatever color they wanted, but they were there with me, being on my team. Luckily, I don't remember much of this treatment because I was so young and so drugged up. I just remember the positives, and I really look forward to when I go back for my visits. I stop by the floors that I was on and say hi to the nurses or doctors that were still there. I think last time I went, there was only 2 of them. It's 20 years removed, so wouldn't expect there to be that many, but it's always great seeing them.
Hello everyone, my name is John Lacerdo. You can call me Johnny if you'd like. I was diagnosed with stage 4 neuroblastoma when I was 4 weeks old. My prognosis at the time was less than 2%. That was back in 1995. I had 2 years of chemotherapy, no radiation, had primary and secondary tumor removal, so it was originally around my adrenal gland, metastasized to liver and bone, and from there a variety of complications. However, at the age of 5 or so, I was said to be in remission. A lot of the lasting effects since then, so chemo at a very young age, for one thing, it killed a lot of my permanent teeth, so I have about 11 implants or so, which required a lot of surgery to get that done. Also, as a result, I have very poor diet, I suppose, due to the fact that the chemo really messed with my taste buds and made me super sensitive to textures and smells and flavors and everything like that. I have chronic chest pains, whether that's from the chemotherapy or from a variety of surgeries, can't really say. I have loss of high-pitched depth perception in my right ear. At the time when they found my tumor, they cut a certain cord near one of my right eye here, which led to a Horner syndrome, so I only sweat on this half of my upper body, as well as you can probably see my pupils are different sizes because my right eye doesn't dilate correctly, as well as my eyelid kind of droops as a result of that. A lot of scar tissue from everything that happened. It kind of grew with me even since I was a baby till now, which resulted in my gallbladder being removed because it was wrapped around in scar tissue like a cocoon and being pulled apart. So, and then there's a variety of other things that have gone on, but it's just a long list. I have a lot of doctors, gastroenterologist, a hepatologist, a cardiologist, specialist for my teeth. My primary care doctor, obviously, I haven't seen my oncologist in a while, but, I'm sure all of you are aware of all the doctors we go through. However, that being said, I am now 26 years old, so I'm still here, and I'm, living my best life as much as I can. I'm in law school, actually my last year, so hopefully in a year I will be practicing law here in Illinois. A little bit more about me. I second generation Italian American. I love breakdancing. I used to make music when I was younger, and I donate all that money to CNCF, which I'm sure you'll hear a lot about. I've been public speaking for, I think, 11 years now. Makes me feel old. Advocating on behalf of all children's cancer, whether neuroblastoma or just children's cancer in general. As we all know, I'm sure, it doesn't get enough attention. So that's one of the big things about me that I try to do as much as I can. I try to not let cancer define me. I know it's been a lot. I wrote papers on this all the time, and sharing my story, trying to help. And I know in high school, I had some moments with some kids, being a little bit more cruel than you would expect, calling me cancer boy, or saying the only thing I was good at was catching cancer. So, but I look back and I realize, they didn't understand it, and to some extent, I wouldn't wish anyone to understand what we go through. However, that being said, there's positive aspects of everything that I've gone through. It's made me stronger, emotionally, spiritually. I've relied on my family, my friends. They understand, and once cancer gets brought up in a family, it's kind of a lifelong battle. That's one of the big things that they don't understand, people that have never dealt with the word. However, with enough resolve, with enough hope and love and support, we can make it through most of the time. And I'm glad to be able to share my story today, and I look forward to talking to everyone. So take care.
Thank you, John, and thank you, Jay. Unfortunately, you can't be here today. But please join me in welcoming John and Julia on screen right now. Hello, everyone. Hi, Julia.
Hi.
Sorry, we didn't have a video with you, but I would like to, have you tell your story. Let everybody know what you've gone through. You've, been at our conferences before and everything. So, feel free to go ahead and share your story with us. And then we'll go ahead and go into question and answer from the audience. Julia.
Thank you so much again. I don't know if you guys can tell, but I'm in my dorm right now. I'm Julia Napso. I'm 20 years old. I'm a sophomore at Fordham University studying natural sciences, considering minoring in economics. We'll see. I was diagnosed with cancer in 9 months old in 2002, around July. And I was diagnosed with stage 4S cancer. My cancer is located in my lower right abdominal area surrounding a special nerve that kind of controlled if I could walk or not. So my parents got together with the oncologist in Royal Oak, Michigan, and they developed a plan where I'd receive chemotherapy treatments for about 2 years and have a final surgery to remove the tumor. Unfortunately, I was super young, so I don't remember much of the treatment really at all. But I've had childhood hearing loss. I've grown up with ADHD, so that was my learning disability. And the only thing that I believe that was really targeted from my neuroblastoma treatment was my hearing. At least that's what my parents and I predict. So, but yeah, I would say that I was lucky because I was caught early on with my cancer treatments, because I was born with actually almost protruding organs. So every 3 months I would have to go in and get an ultrasound to make sure stuff is where it's supposed to be right after the surgery. And so when I came in for the third time when I was about 9 months old, they caught the tumor. So luckily that was just kind of my story, because I was so young, they would have never noticed.
Right. Now, and because of the lack of side effects and everything, but the fact that you know about it, how does anybody ever ask you anything? Is there any, outward appearance from you or anything that they would know this?
I think the most interesting story I have from someone kind of realizing about it was when I met my boyfriend. I I was about to finally get my final hearing surgery to repair my hearing in my right ear because I was already able to hear my left ear. I went to this program where the entire time I just did not have my hearing aid in my right ear. So if you were talking to me on my right side, I could not hear you at all. But if you talked to me on my left side, I was completely responsive. So I remember after the program, he asked me, and I was like, "Oh yeah, I just can't hear in that ear." He was like, "Why?" I'm like, "Oh, I have cancer." And he was like, "Oh, here we go."
Yeah, yeah. And Johnny, did you have any issues that way, or?
Outward wise, yeah, like Jay, I have a scar that starts kind of on slightly left of my abdomen, and then it wraps around to almost the back of my spine, right behind my neck. It stops at some point, but it grew with me. So whenever I went to like a public swimming or anything, people would notice, and that's why in high school I did not do gym class, because I was like, I do not want to have people asking me about this when they already know about me. But that's the last thing I wanted, was like more looks. So, and then my eye. I mean, I had a high school teacher pull me aside. He thought I was on drugs because my pupils were not the same size, and I was like, no, it's a Horner syndrome. I'm in remission from cancer. Like, and I had to give this whole spiel, and it just like, and he didn't mean anything by it, but like, that it was just one of those moments of like, oh God, I have to explain this now.
Yeah, no, I have the same experience where I had a 504 learning plan. And so actually for every semester in high school, you have to have this paper signed to let your teachers know that you have a 504 plan, except some teachers wanted to know why you had the 504 plan. And my medical history outside of just the cancer treatments itself is already extensive. So I just remember sitting there and be like, well, do we have an hour for us to just sit down and go through all of this? Because if you really want to know how much.
Right. So
Yeah.
almost like you want to wear a billboard.
Yeah, it would make it so much easier.
It would.
Sometimes. Because people just wouldn't have any more questions. You're just like, here we go. And they're like, oh, okay, perfect.
Right. Yeah. Now, and especially, did you feel different? Again, both of you were very, very young when you had your treatment and everything. So now, did your life or your thought process or adaptation to it all change, like from childhood to adolescence to teen to adulthood? Did you have any kind of like epiphanies or anything like that, or?
Okay, I would say for myself, it was more of, I didn't know anyone. I was from a very small town in Michigan, so I didn't really know anyone who had cancer treatments or had really remotely the amount of like disabilities I had growing up, just because it was such a small town. And I would say my class size was about 30 people every single year.
Oh.
So I think my first time actually seeing a group of people who were similar to me was when I actually attended the first conference at CSC.
Okay.
Yeah. So I believe that was just for me. Otherwise, I think really the most prominent thing I was surrounded by were people who needed glasses.
Yeah. Johnny? Because I've got some questions coming up too, so we'll be ready.
Okay, I'll try and answer quick, I guess. I guess I just noticed right away, like when I was probably 4 or 5, I started noticing like all of my friends didn't talk about going to the doctor, and I was like, this seems weird. Like, isn't this what everyone does? And so, I asked my parents, and they kind of sat me down at a young age. Again, I didn't really understand it fully, but I think my real epiphany was probably when I was like 10, and I was then it was Children's Memorial Hospital. Now it's Lurie's Children's, and on the cancer floor, I remember sitting there and I was complaining. I was like, I don't want to be here. I'm sick of this. I'm sick of needles. I had a huge fear of needles, and I didn't want to be there. And I remember this 4-year-old or 5-year-old kid, really young, and he just looked at me. He was hooked up to an IV bag. He said, I just want to get better. And I was like, oh boy. I was like, and so from then on, that kind of changed my perspective and perception of everything else. So yeah, I guess that answers that.
Yeah. Here's one of the first questions for both of you. Do you feel that you grew up having all the support you needed to deal with what happened when you were little? Is there anything that doctors need to know to do better? Julia, you want to start?
Sure. I think I had great support system growing up. Both of my parents were very supportive. My sisters, both younger than me. I remember I had this one scar where I don't have a belly button. So I have this one scar that's supposed to be my belly button. And so I always thought it was really weird because I'd have to do extracurriculars that change. And people would be like, oh, what's that? And I'm like, oh, it's my belly button. They're like, that doesn't look right. I'm like, I know. And so my sisters would come and be like, oh, it's a sunshine or it's like a little star. And so, like, I think I always remember that. And that always, like, roots me a little, just a little bit more. And then I think anything that doctors and parents really just need to know is that for me, I think what was good for me was how would have been knowing kids who were similar to me so that I wasn't just surrounded in a mystery of what would possibly happen. Because for me, if going to the doctor was very common, like John was saying, so I just never, and when my friends would be like, oh, you go to the doctor so much, I was just like, oh, I do?
Yeah.
So it would have been nice to be able to have that friend who's just, I could go and be like, oh, you went to the doctor again? Like, so did I. It's like, that's crazy.
Mm-hmm.
So,
Yeah.
I guess for me, like I said, Italian American, so big Italian family. Everyone always been super supportive. You know, there's been times where some family didn't really completely understand, or they might say, "Oh, I know exactly like what you went through," and it's like, I don't know if you know exactly, but like I appreciate what you're trying to say. I guess, and for the doctors, my biggest thing that I had growing up that was an issue, and there were doctors I walked out on, you know, we're not science experiments. Whatever our problems might be, addressing them correctly is a big thing. I know, and I don't know who they were, and I wouldn't name them anyway, but when I was trying to figure out what to do with my teeth, they said, "Oh, we're happy to take the challenge." I stood up, I said, "I'm not your science experiment," and I left. You know, we are not, that's not what we are. You can address it like we're trying, you know, we'll try and help any way we can. That's fine. But so that's what I would say. And then just one other thing that I don't know if this is really heavy for the first question, but one thing I know I deal with, I don't know others. I know I've spoken with some survivors. Survivor's guilt is a big thing that growing up I've kind of dealt with on my own up until the point where I was like, you know, there's no talking about it now as much. But when I was younger, it would have been nice to kind of talk about that. But as a kid, you don't know what this feeling is and how to really express it. So doctors and parents might, you know, think about how to address that possibly.
Oh, Julia, did you want to say anything on that or no?
yeah, I do believe I did have a brief period in my life where I didn't consider myself a cancer survivor because I didn't remember anything. Because I didn't remember anything, so I would watch conferences with kids giving speeches about their survivorship and how they remember losing their hair and shaving it off, and I never really had that. So for me, it was like I never had like that emotional like tag to myself that would really define survivor because I don't remember. I don't have PTSD from it. I don't remember anything from it. I think the most I could say is my fear of needles because I'd always have to get my blood drawn every year. So otherwise, yeah. So that's where I was always wanted like that one other person who would be with me, who was alike to me, and we could talk about that together. Because as a kid, I just didn't know.
Right? Yeah. Okay. The next question. You're very well informed about your medical history. What suggestions do you have for parents on how to share information with kids who might be too young to remember? So in both of your cases, you know, how would you want information to be shared with you?
I guess, so I think when I figured out I had cancer, I was about 5 or 6 years old. I would nag my parents about my port scars constantly. I'm just like, what is this? What is this? And they're like, oh, should we tell her? Maybe not. Like, she's a bit young. I think it's appropriate, I believe, to say something at a younger age because that's when it's more commonly associated and it's when it's normalized. So when you're older, it comes off as something strange and something unusual, but at a younger age, you're able to kind of embrace it more and take it with like a grain of salt. You know what I mean? It's not a huge explosion, right? Because a little bit, yeah, you don't understand, but as you grow up, you can guide and like teach and have your kid learn about what had happened. So that was my Yeah.
Yeah,
Mhm.
I mean, I echo that too. Pretty much just, trying to explain to them the best you can. You don't have to give all the horror story details of what you experienced, with your child. Because I know my mom, like, every doctor's visit, she relives it. I see it in her eyes, and I don't know what that was because, I was too young. But just starting off with, you had something called neuroblastoma or whatever type of cancer, and then just having a conversation saying, you were sick, you're better now, and we're just, this is what we have to do in order to make sure that you stay better and, you can live a long, happy life. And then, as they get older, they'll probably ask you more questions, and then you can fill in details when you think they can understand it better, I guess.
Mhm. Yeah. Another question pretty much related to this. It is wonderful to hear your success stories, and thank you so much for sharing them. I was wondering if you still get routine scans to detect neuroblastoma, and if you do, how does this impact you emotionally at an older age where you understand what the scan is about? Hmm. Okay. Do you get scans? Do you get scans? Do you go for follow-up anymore, or is that done?
That was a while ago. I think for me, I would say that I just was used to it. I just knew that every so often I'd go in, and I remember specifically, I did not get like getting the IV when I did get my MRI scans, and so my parents would have to bribe me. Either my dad would come and hold me down, or my mom would have to bribe me if she came with me. And so my mom would bribe me because there's a Arby's right next door. She's like, "I'll get you a roast beef sandwich if you just like lay down and take this IV." I'm like, "Okay."
Mhm.
And so that was always like the thing. I get the MRI and we go get a roast beef sandwich from Arby's. And so I would say, no, currently I don't. I would sometimes, there's one clinic back in Michigan where I would go and visit just for like case studies, primarily, just as an adult with neuroblastoma, like who was diagnosed with neuroblastoma at a young age and like now it's in remission. I would say that's really the only screening I do now, and that's annually, and it's not required. So,
Mhm.
Mm. Yeah, as for me, I haven't for a little bit for personal reasons, I'll just say. But for the most part, I mean, I get scanned for so many other things. Like this year, I've already had probably five. So, and related to either my heart, my liver, other things. So, um, plus with law school, work, and pandemic, everything's just there's been so much going on that sometimes I'm like, do I really need to go to another doctor? Like I've been to seven already this year. Like, do I need to see more? Like, I know I should. I just sometimes things get crazy and hectic. So I haven't for a while now currently, but
yeah, same
probably
here.
will.
Same here. Because I'm now in New York City for school, so none of my doctors are here. And also, I've hit that age where I'm no longer pediatrics anymore.
Right.
Mhm.
I'm an adult now. So, and that happened during COVID. So all of the referrals I would have gotten, etc., that I should have gotten when I was 18, my last year of pediatric rounds, I didn't get. So I really have no new doctors. I haven't got my heart checked out in a bit. That's been nerve wracking, but hopefully I'll find one.
Yeah.
Yeah.
The next question, do you ever mentor any children or kids today in your same situation? Do you ever see any or go to the hospital and visit or anything, where you would possibly mentor another patient?
Currently, I don't. I know for some time I tried to talk to two individuals, but I had never met them. It was because they lived in another state, but I tried talking with them, and it just seemed like maybe it was because there was that barrier of they had never met me or something, but like, there wasn't long conversation, and they didn't seem to want to talk about, anything related to neuroblastoma or cancer related at all. And so I think maybe part of it, their issue was, interacting with people on a social level because they already felt like there was something going on, and so they didn't connect with someone. I don't know. I haven't currently. I'm always open to the possibility to, I've tried, and I talked to other survivors I know that aren't neuroblastoma specific. Yes, that I have at least one friend who I know went through some similar things. So like we've talked about things, but currently not mentoring anyone right now.
Okay. Julia, anyone?
Not that I know of personally. Out of my own social circle, I'm really the only one who had cancer in it. So, so I never had either the opportunity to mentor someone. So, but I'm always down. If someone, I'm more than willing to share my contact information if anyone really wants to. So,
okay, all right. John, this question is for you. Is regarding at what point did you intervene with your dentistry issues?
Yeah.
That's, I know you had extensive work done and everything, because this one mom is saying that her daughter has some issues she'd like to address.
Sure. Okay. So I was really lucky with the fact that my original dentist, he very wonderful person. He also had some experience with working with cancer patients before, and so he noticed these things early on for me that they were going to be issues. So when I hit the point where I needed braces, he recommended me to some ortho specialist who had also dealt with cancer patients before. So I guess it started then. And then the ortho specialist there put me in touch with a prosthodontist specialist who had also worked with cancer. So it all revolved around the fact of like your doctor or dentist knew somebody that had experience with handling, people that had had chemotherapy. And then from that, they all have a variety of experience or other contacts that they have to get you what is necessary. I think the biggest hurdle, which is getting the insurance to recognize that it is not cosmetic, because that was a big argument for a long time that with our insurance company about, they said it was cosmetic because I don't know who, but some doctors or some organization did a study and it was, oh, you don't need all your teeth to live. And it was like, that, you're really going to say that? Like, that's no. So that's the biggest hurdle, I think. It's not necessarily finding the doctors for it. It's more getting the insurance to recognize that, because it's a very expensive ordeal. And I know, our families have already gone through enough in paying medical bills, let alone more.
Yeah, for sure. The last question here, let's see. Okay. Have you, you had, follow-up care and stuff after treatment, your scans and everything. Do you do anything at all, as regards to, follow-up care, or are you just kind of going on your way? One of the parents is asking if there's anything, that you've learned from the experience transferring or transitioning from pediatrics to adult, and how much do you have to explain to them?
Yeah. Sure. So for transitioning, because I just like 2 years ago, I had to transfer to a general practicing doctor because, too old to see my pediatric doctor anymore. But the process was good. I took a big initiative of looking for a doctor that I felt was going to have a good understanding of how to treat me. So one thing I looked for, and this is not anything against MDs, I looked for someone that had DO, doctor of osteopathic medicine, because I know like they have that inscribed philosophy. That was one of the things that I kind of gravitated towards. Obviously, all my medical doctors are great too, and I love them all. It's just that was what I wanted for that, only because I, having to deal with all of the things that could happen to me, like, they're gonna have to be comfortable with that, and I'm gonna have to be comfortable with them. So I guess that was my experience, and they've been on top of everything since, even the littlest thing, they're like, this could be nothing, but I'm still gonna make sure you get checked anyway, because I'd rather be safe than sorry. And I'm like, all right, that's fine. So yeah.
Right. Julia, anything in the transition or no?
I'm currently still trying to go through the transition, just gambling with a lot of school. I do still have chemistry homework. So finding those new doctors have been a little bit of a struggle for me since I have to find them back in Michigan.
Yeah.
Because I'm not from New York, unfortunately. So it's just that gamble of just seeing if I can find it and it's finding when I'm going to be back to see that doctor. So,
All right, I have one. Oh, sorry. There's one last question. This one's for Julia. And then we'll have to end the session here. Do you believe your ADHD is chemo related? I've seen a few parents talk about chemo-induced ADHD, and is this treated differently, ADHD for non-cancer children, or ADHD for non-cancer children?
So from what I'm familiar with is that my father does have some form of ADHD or ADD. He was just never diagnosed by a true psychiatrist. So there's the chance that I either got it from him, since there's a 50% possibility that the firstborn could have ADHD. ADHD if one of the parents did have it. So there's that possibility that the ADHD was not induced by my chemo, but we're not fully sure on that aspect because there's just so many factors that you just have to monitor. Compared from my treatment to my friends who have not had cancer but also are ADHD, treatment plans have been similar. I take Vyvanse 30 milligrams every single day, but I tend to take it whenever I really need it because I don't want to increase any tolerance to such medications that are so strong. So, and then I do have like a Adderall booster that I rarely use. So, and that's pretty similar to most of my friends who also have ADHD, but did not have cancer treatments. So,
okay. Okay, let's see. Anything else? I think we're just about done. Okay. One quick question. I think we have like 2 minutes. Is there anything you would like to say to the parents in the audience? As you know, they're probably scared and fearful of what's going on with their child, to maybe ease their minds a little bit, as they go forward through their journey. Is there anything you would like to say to them?
I guess I can try to say something. Like I said in my video, my prognosis was less than 2%. And even today, none of my doctors know how I made it through. But I have a firm belief that whatever your belief system is, if you're religious or not, but having that family that cares and having doctors that care really makes the difference. And I know no amount of words can ever really convey the difficulty that, this is. But at the same time, you have to look at that and appreciate everything you have. And then that you can make it through. It is a lifelong battle, but you know what? Like, at the end of the day, with love and support of your family, you can make it through. So that's, I can convey to the best of my ability. So, yeah.
Thank you, John. Julia, anything?
I agree with John. It's really just a loving and strong support of family and a good medical team that really does make a difference. Even post-treatment, just still having that support, continuing on even in the aftermath is vital because kids who were diagnosed with neuroblastoma are super young. So they can't recollect what had happened or they just don't remember. So just guiding them and giving that love and support and kind of teaching them in a loving and nurturing way of what happened and telling them that it will get better is really important. And it really it really makes a difference from what could be seen as negative to what can now be looked at positive. Right. So.
Yeah, for sure. I can tell all the people who are watching this share love with you and wish you the best and have great outcomes. And if you ever need a lawyer, you contact Jeff.
In the state of Illinois.
In the state of Illinois. All right. All right. But yeah, we wanted to thank you both for joining us and everything. It's been a great conversation, and we wish you the best. And like I said, I know everybody's putting their arms around you and looking for bright futures. Thank you very much.
Thank you, everyone.
Thank you.
Thank you. Again, I'd like to thank our speakers. I'd like to thank everyone for watching and asking questions at the symposium. We've reached the end of this session, as well as, the Neuroblastoma Symposium. But before we close, on behalf of all three of our organizations, I would like to say a huge, huge thank you to our host, Dr. Daniel Morgenstern, for taking this role on this year as well as last year, and for all the support he has given us, for the past year and a half. And I would also like to remind you that the videos from yesterday are available on demand, and you go to the left page of the event platform, and you will find the videos there. And to complete the survey, we would love to hear back from you, what we can do better, what we can do differently. That too is also on the left side of the event platform. So please do fill out the survey form, and we'll do our best to make things even better as we go along. And I would like for you to join Dr. Morgenstern back here, we're 2 minutes late, sorry, for his closing remarks, plus a moving tribute to all of the children and the young people from around the world we are here united for. Thank you again for being a participant and for listening to everything. Thank you.